Thank you, Ellen, for that lovely introduction. I just turned the microphone in this pocket on. I think that's the right one, but I want to make sure that everyone can hear me in the back. Okay. As Professor Clayton just made clear, and I want to reiterate before I launch into this lecture, I am neither a geneticist, nor a theologian, nor a bioethicist. I'm an historian who has spent the last 25 years reading the works of geneticists, other medical professionals like genetics counselors, theologians, and bioethicists. So I am going to talk tonight from the perspective of an historian, but without the deep expertise of any of those fields. So if I should, and I know that there are many people in this room who have deep expertise in those fields, if I should make errors of fact, or I should gloss over complexities, please forgive me and ask me about them calmly, I hope, in the question period. But I'm trying to squeeze a lot of material, some of which is technical, into a half hour or 35 minutes. And in my effort to do that, I am going to have to simplify some things that are, in fact, rather complex. My lecture tonight sits at the confluence of biology and culture. Because for most of human history, human beings have tended to mate with people who lived near them. Disease mutations, when they once appeared, have tended to cluster and to spread in what we call ethnic communities or ethnic groups. And since these mutations result in fundamental and lifelong alterations of the body's normal physiology, genetic diseases tend to be very, very serious diseases, often, if they can't be treated, fatal at early ages. Those are the biological facts. The cultural fact is that members of the same ethnic group tend to share the same religion. And that means that clergy stand at the intersection of these biological and cultural facts. And that means that for roughly the last 50 years, since once fatal diseases, since treatments have been discovered for some of these once fatal diseases, clergy have shared with their congregants some truly dreadful clinical experiences. In addition, since the advent of genetic screening, which you may be surprised to know also happened almost 50 years ago, clergy have shared with their congregants the necessity of making some truly gut-wrenching ethical decisions. In their effort to help their congregants, and sometimes themselves, since genetic diseases are not respecters of professional identity, in their effort to help their congregants and themselves find a moral path through these very troubled waters, clergy have, as a consequence, regularly found themselves having to balance conflicting ethical imperatives. Out of this struggle, that is, to find a moral way in a difficult decision environment. Clergy and congregants together with medical professionals have created some new social institutions, and these social institutions, genetic screening programs of various sorts, have incorporated in them some new ethical pathways that clergy have pioneered. Pathways that on some occasions, and I'm going to give you some examples, have caused clergy to bend some old theological rules. So when I wrote the abstract for this talk, which is in your conference booklet, I said I was going to give 3 examples. I actually came up with a 4th in the process of writing the paper, and I'm going to try in the time that I have to squeeze in that 4th one as well, because the first 2 concern Ashkenazic Jews, one or several communities of faith. The 3rd concerns the Cypriot Orthodox Church, a very different community of faith. And the 4th, which I hope to find time for, concerns the Roman Catholic Church in the United States. So let me start with Tay-Sachs disease. Tay-Sachs disease is one of the most dreadful of all the dreadful genetic diseases, partly because it causes the death of babies born with it before they reach toddler age, which they don't actually reach because of the disease. That is, they would reach it if they didn't have the disease. And also because at this very moment, it is still untreatable. Tay-Sachs disease is what is called a single gene recessive disease. And that means that people who have only one copy of the mutated gene, these people are called carriers, are reasonably healthy. They certainly don't have the symptoms of the disease gene that they carry. But if one of those carriers should happen to conceive a child with a person who is also a carrier, then there is a 25% risk, 1 in 4 risk, that that child is going to be afflicted with this disease, is going to be a heterozygote, a homozygote, is going to have 2 copies of the mutated gene. And as most of you probably know, the carrier rate for, or rather Ashkenazic Jews, the Jews who originated in, or lived for many millennia in Eastern and Central Europe, have a very high, one of the ethnic groups that have a very high rate of carriers for Tay-Sachs disease. The disease process in the child is one that causes infinite suffering for the parents. Because of the mutated gene, a fat-like substance gets deposited in the brain of the afflicted child, actually begins to be deposited even when the child is still a fetus. And that fat-like substance, as it accumulates, destroys the neurons in the brain. The baby will seem robust and healthy for the first few months of its life, but it will then start to lose its eyesight and miss important developmental milestones like crawling, holding on to objects, babbling, talking. By the age of 2, the child will be more or less vegetative, and a year or 2 later, the child will be dead. In their struggle to deal with the ravages of this disease, rabbis and physicians have created 2 new social institutions. They are somewhat different from each other in some ways, but very similar in another way, which I'm now going to try to explicate. The chronologically first of these new social institutions what is now called a community-based genetic screening program. That is, a genetic screening program which occurs outside of doctors' offices, or genetic testing which occurs outside of doctors' offices. And the community institutions in which the early carrier screening programs for Tay-Sachs disease took place were synagogues and Jewish community centers. The programs were created to identify previously unidentified carrier couples through carrier screening, which involves nothing more for the individual than a blood test, and to counsel the carrier couples about the reproductive options that were available to them in the early 1970s, one of which was prenatal diagnosis for Tay-Sachs disease. That is, procedures which could be carried out in the second trimester of a pregnancy to determine whether or not the fetus being carried by that pregnancy was or was not a homozygote, and legalized abortion if the parents so choose, having discovered that the fetus was indeed a homozygote. These programs were created in the early 1970s by a small number of devoted Jewish physicians working in concert with Jewish social workers, and the first of the so-called genetic disease advocacy groups, the National Tay-Sachs Disease Foundation, which had been created in the mid-1960s by a group of Jewish parents of Tay-Sachs children. As I said, in the early years, community-based screening for Tay-Sachs disease operated out of a few synagogues and Jewish community centers whose leaders had decided, and this is where the conflicting ethical injunctions rear their heads, whose leaders had decided that the biblical commandment to be fruitful and multiply, and their more secular desire, this is the early 1970s, the generation of Jews having children is the post-Holocaust generation. Their more secular desire to replace the 6 million Jews who had died in the Holocaust as quickly as possible outweighed the Talmudic authorities who argued that abortion is almost the equivalent of murder. Today, because carrier couples can be identified in prenatal care, the screening programs that still exist are premarital screening programs. That is, they attempt not to identify couples, but to identify individuals who are carriers before they actually marry. And they operate these programs principally out of Hillel, the college campus ministry to Jewish students, whose leaders, many of them rabbis, have made the same judgmental call. The second new social institution that has arisen in the Ashkenazic Jewish community is called Dor Yeshurim in Hebrew, the Committee to Prevent Jewish Genetic Diseases in English. Dor Yeshurim was founded in the 80s, a decade after the community-based screening programs I just described, by an ultra-Orthodox rabbi who had fathered 4 Tay-Sachs babies and the Jewish physician who had diagnosed the malady from which the rabbi's children suffered. Dor Yesharim is a screening program designed to serve the needs of Jews who refused to make the same judgment call that the Jews who designed community-based screening had made. That is, Dor Yesharim is designed to serve the needs of Jews who will not countenance abortion, even for such a severe malady as Tay-Sachs. Dor Yesharim is essentially a genetic registry. Young unmarried men and women send blood samples to the registry and receive, in return, by mail, identification numbers. When a marriage is planned, a telephone call is made. The two ID numbers are submitted for counseling, and the counseling consists of a return telephone call, which tells the individuals that the marriage either is or is not advisable, and very little more. Apparently, this negative news is sufficient to send each of these young people off in search of a different marriage partner. We know this from the fact that Dor Yesharim, as the community-based screening programs, have been enormously successful. By the late 1990s, no more than 1 or 2 Tay-Sachs babies were being born to Jews in any given year, not just in the United States, but all over the world, in any country that has a reasonably advanced medical infrastructure and more than a handful of Ashkenazic Jews. So in their details, these two programs differ from each other. One is a registry, the other is a community-based screening program in which people are told exactly whether they are carriers and of what or not. But they both have arisen from the effort to reconcile conflicting religious injunctions. The first injunction is the biblical commandment to be fruitful and to multiply. The second injunction is, wherever possible, to reduce pain and suffering. And the third injunction is that abortion is forbidden. My third example is from the role played by the Cypriot Orthodox Church in creating a genetic screening program which is different from the two for Tay-Sachs in being mandatory, not voluntary. This program exists in the Greek part of the island of Cyprus, the part of Cyprus which is today called the Republic of Cyprus. The genetic disease that the Cypriots screen for is called beta thalassemia. Like Tay-Sachs disease, beta thalassemia is a single gene recessive disease. And also like Tay-Sachs, it kills the children who are born with it before they reach their 6th birthday. Like the Ashkenazic Jews, the Cypriots have one of the highest carrier rates for beta thalassemia in the world. 1 in 7 Cypriots carries the mutated gene. Unlike Tay-Sachs, however, beta thalassemia has been treatable since the early 1970s. When a drug was discovered that allows babies born with thalassemia to live well into adulthood, reasonably healthy lives into adulthood. Unfortunately, the treatment regimen for thalassemia is almost as awful as the disease. It involves a daily regimen of infusion of the drug using a small portable pocket-sized pump. Thalassemics inject a hollow needle into one of their veins, and infuse the drug, which is called desferal, over a period from 8 to 12 hours every day. They also have to undergo a monthly regimen, receiving high concentrations of red blood cells by transfusion in hospitals and clinics. In the mid-1970s, which was when this treatment became generally available all over the world, the Cypriot economy was still undeveloped. The treatment had actually been developed in Britain. Cyprus had been a British colony until 1960. By 1970, it was on a path to development, but it hadn't reached it yet. On top of which, the Cypriots, Turkish and Greek, were in the midst of a bitter and long-lasting civil war. At that point, that is in the mid-1970s, the treatment regimen confronted the Cypriot, for thalassemia, confronted the Cypriots with an awful moral dilemma. Because the regimen is expensive. Not just in funds, the drug, desferal, was at the time extremely expensive, and it still is, but also in blood, since every thalassemic has to have a double concentrated blood transfusion once a month for his or her entire life. The Cypriot medical community, or that is the part of the Cypriot medical community that was caring for the thalassemic patients, realized that if their socialized medical system continued to provide the medication for thalassemia and the blood transfusions for thalassemics, and the numbers and the life expectancy of the patients continued to grow, within a few years, the cost of the medication would overwhelm the budget of the Ministry of Health, and about a decade after that, the entire public treasury of the island. In addition, if the number of thalassemics continued to grow and their life expectancy continued to increase, by the time 15 years had passed, every Cypriot adult would have had to donate blood. Every single Cypriot adult would have had to donate blood every 6 weeks. In an effort to get themselves out of this moral dilemma, the physician specialists in caring for thalassemic children and their families collaborated with the Parent Association that had been created on the island in the late 1960s to create a voluntary genetic screening program and to raise, or to rather to lobby the government for funds to send carrier women married to carrier men to London when they were pregnant for prenatal diagnosis and, if necessary and wanted, abortion. This program, as I just explained, combined carrier screening with another form of screening, that is prenatal diagnosis of fetuses, and abortion to prevent the disease by preventing the birth of additional babies afflicted with it. The program, voluntary program, was not as successful for a host of reasons which I will discuss in more detail in my presentation tomorrow morning. The program was moderately successful, but not nearly as successful as its creators had hoped. So in the early 1980s, the physicians and the parents turned to the leaders of their established church, the Cypriot Orthodox Church. And they requested the church to assist them in creating a mandate for genetic screening. Despite its adamant opposition to abortion, in 1984, Archbishop Chrysotomos issued a declaration allowing priests of the Cypriot Orthodox Church to request that each party to a marriage present a certificate saying that he or she had been screened and counseled by a thalassemia expert before the marriage ceremony could be celebrated. This quasi-mandated program has been very successful. Almost the week after the edict was promulgated, every priest on the island began requesting the certificate from couples about to be married, and virtually all couples voluntarily agreed to acquire it. As a result, no babies with thalassemia have been born on the island, or rather in the Greek part of Cyprus, since the early 1990s. The birth rate has fallen, for thalassemia has fallen to 0, and it has stayed there. The leaders of the Cypriot Church, in permitting this program to go forward, were admitting their willingness to bend their theological rule prohibiting abortion in order to reconcile exactly the same conflicting moral injunctions that the Jewish rabbis and community leaders and physicians had tried to reconcile. What they seem to be saying by permitting their priests to request these certificates is that abortion is, yes, murder, but if it enables people to reduce pain and suffering, and it encourages them to be fruitful and to multiply, it may not be a sin. If you'll bear with me for 5 more minutes, I'll give you the 4th example quickly and then sum up. This example comes not from my own research, but from research done by a medical anthropologist by the name of Deborah Blizzard. And if you are interested in learning more about it, I recommend her book, Looking Within, to you. The example is a little bit of an outlier because the disease in question, twin-to-twin transfusion syndrome, or TTTS, is probably not genetic, and it does not appear to be concentrated in any particular ethnic group. Nonetheless, this is a disease which, because it occurs in the womb, because it afflicts fetuses, it is diagnosed by one of the technologies that was developed to aid prenatal diagnosis, ultrasound, and it is treated by another one of those technologies, Fetus Coupee. And for these 2 reasons, I believe that the case of twin-to-twin transfusion syndrome can be considered a product of advances in genetics and genomics. TTTS results from abnormal and uneven placental blood flow between identical twins. In TTTS pregnancies, one twin becomes anemic and the other twin bloats with excess blood. Outcomes of the disease are various, but almost none of them are happy. Often both fetuses will die in utero. Sometimes only one dies, the anemic twin. The other is born live, but is almost always neurologically impaired. Less often, both twins are born live, and in that circumstance, almost always, both of them are neurologically impaired. Now, fetoscopy, which is a procedure that allows the fetoscopist to see into the amniotic sac, to see the fetuses. Fetoscopy can be used to treat TTTS in two ways. The first way is by attaching a tiny laser to the fetoscope and to cauterize the blood vessels that are connecting the twins so as to stop the blood flow between them. If that fails, and one of the twins continues to decline, then physicians can couple the fetoscope to tiny surgical instruments, and they can ligate or tie off the umbilical cord of the weakest infant, thereby killing it and saving the other. In the mid-1990s, according to Deborah Blizzard, a Catholic specialist in fetoscopy was practicing in a Catholic hospital in upstate New York. And he asked his bishop for permission to move, if necessary, from fetoscopy for cauterization to fetoscopy for ligation. His bishop granted permission for him to do that under the ancient Catholic doctrine of double effect, which, since I am not a theologian, I will quote from the works of a theologian. The principle of double effect holds that an action should be performed only if the intention of the action is to bring about the good effect, in this case, saving the struggling fetus. And the bad effect, that is, in this case, killing the dying fetus, will either be unintended or indirect. Whether or not we agree with the bishop's judgment in this case, I hope that we can at least agree that his effort to skirt his church's injunction against abortion was motivated by his compassionate and therefore moral effort to reduce the pain and suffering of the parents of such twins. And that example leads me to a disclaimer that I want to make by way of conclusion. I don't agree with all the judgment calls that were made by the actors in my story, and I suspect that you don't either. I do, however, believe two things. The first is that modern genetics and genomics have created, through the potential of genetic screening, the need for some very difficult ethical decision making. That's the first. The second is that in their effort to find their way through these very, very troubled waters, medical professionals and clergy, and the clergy that I have told you about tonight, have been acting, to use a phrase from the work of another medical anthropologist, Raina Rapp. They have been acting as moral pioneers. Thank you. I have told Ellen that I will field my own questions, so go for it. Yeah.
I apologize, my information about genetics stopped in 9th grade. But
Yes, and I apologize. There was just nothing I could do in the time I had to be clearer.
About each parent being a carrier.
Right.
If each parent is a carrier, is it possible that they could have a child that did not have the
Yes.
condition?
Yes. Remember the Punnett squares that we drew in high school biology?
Right, exactly. That's what I was thinking.
Right.
It was possible. So when you're talking about counseling, odds are against it, but there is a possibility that they could have a child that would not have Tay-Sachs.
There are 3 possibilities that can result from the mating of 2 carriers. One, which is going to happen 50% of the time, or to put it more accurately, the risk of it happening is
Greater than not.
is 50-50 in every pregnancy.
Okay.
Okay? And that is that the child will also be a carrier. That is, the child will be a heterozygote. It will have the dominant gene, which will be expressed for the chemical needed, and it will also have the recessive gene, which won't be expressed for this particular chemical. Okay? 25% of the time, or there's a risk, there is a 25%, 1 in 4 risk in every pregnancy of 2 carriers, that the child that results will be a homozygote dominant. That is, it won't have the symptoms and it won't carry the gene. So that leaves a similar risk, 1 in 4, that the child that result will be a homozygote recessive, and those are the afflicted children. And that's why in some of these programs, genetic screening to identify carriers is coupled to prenatal diagnosis, because through prenatal diagnosis, you can find out whether the child is afflicted.
Which group it fell into.
You can't find out which group it
Well,
falls
whether or not
into.
It is going to have it or it isn't going to.
That's it. 75% of the time, the fetuses will not be afflicted. 25% of the time, they will.
Is that the same type of setup with Huntington's disease?
No, Huntington's disease is crucially different in being a single gene dominant,
Okay,
not a recessive.
thank you.
Yeah.
I was wondering that if you have a situation in which a mom knows that if she continues with the pregnancy, it might kill her. And, you know, but she persists that she doesn't want the abortion.
Right.
What should a doctor do at that position?
What should a doctor do? Well,
You know, is that a
the law requires the doctor to follow the mother's, if I understand it correctly, and there are people who know more about this in the room than I do, so correct me please if I'm wrong. American law requires the physician to abide by the mother's wishes.
And isn't that suicide or not?
Is it suicide?
Not if you consider the hand of God. There's miracles happen all the time.
If I might answer that question.
Yes, please. I can't.
My mother was born in 1926, dead in 3 pounds. Her mother had rheumatic fever and was stroking out at the time. She was revived. She died again the second time on Christmas Day.
That is your grandmother.
My mother
Your mother.
died the second time on Christmas Day 2 years ago at the age of 76, having been born dead in 3 pounds in 1926. And my grandmother delivered 3 more children that were live births. It couldn't happen, but it did.
Right.
You had to leave God in the picture.
And would you rephrase that, that story that you've told us so that it directly answers this young man's question? Do you consider correct me if I'm wrong, your grandmother's decision to continue the pregnancy despite the fact that she was having a stroke? Was that?
She had rheumatic fever.
She had
her heart by the time she died was 4 times
Yeah.
the size.
Rheumatic fever was one of the conditions that was made, well, it made if you had it, your pregnancies were always high-risk pregnancies.
Yeah. And she had 3 more live births even despite that.
I should tell you that this situation in which the continuation of a pregnancy threatens the life of the mother is also addressed by the doctrine of double effect. That is, prior to 1973, prior to Roe versus Wade, when many states had laws outlawing abortion, there were exceptions to those laws when the continuation of the pregnancy threatened the life of the mother. And those exceptions were advocated originally in the end of the 19th century when the laws were first created, was often advocated by Catholic physicians and Catholic clergy under the doctrine of double effect. Now, in a papal letter in 1930, the then Pope, what's the correct verb? Decreed that the doctrine of double effect was a mistake. And the phrasing, which is quite famous from that encyclical, is 2 deaths are better than 1 murder. These ethical issues, to put the matter another way, are not new. Yeah.
I guess in this session that we expect to attend is to carry on, not necessarily to determine ethical or moral issues for society, but as a health caregiver, I'd be interested to expand to do no harm effect to the patients that I serve, but yet at the same time interacting with the disciplines that also have to uphold the religious and social impact and the economic and political impact of our society, not only here in the U.S., but elsewhere. So the world is approaching a huge, we don't know where genetics is going to lead us, and we don't know the effects and consequences of that science. So as a health caregiver, it's one thing to be able to educate patients that we serve, but it's another thing to help them decide given the disciplines that we're working with. So as you expose those 4 instances of determining ethical and moral issues, we have the reality of life. And I guess when you look at the question that he asked and the experiences that you asked and the role of religion and spirituality in our life, the quandary that I see is that sometimes we install in our teaching.
I'm sorry, did you say sometimes we stole?
Install.
Oh, install.
Fear and anxiety that might not necessarily have to occur, or sometimes it should.
Well, if I can speak for the organizers of this conference, I think it's fair to say that you've just summed up their entire reason for calling it. Is that? I suppose I have to say first that I do have a comment to make, but also that that's exactly what we're going to be talking about for the next 2.5 days. Day and a half. I left out the injunction "do no harm," which is an injunction in medical ethics or in professional ethics for physicians and other healthcare professionals. Not because it isn't important, but because, in fact, it was the conflict between that injunction and the more modern medical ethical injunction, respect the autonomy of your patient, that first drew me into historical study of this situation, because when genetic screening, or rather prenatal diagnosis, was first being developed in the late 1960s and early 1970s, the first condition, and for almost a decade the only condition that could be diagnosed prenatally, was sex. And this led physicians to a consensus conference at the Hastings Center in late 1970, I think it was 1978 or 1979, to discuss what a physician should do when a patient wanted to terminate a pregnancy because the fetus being carried was not of the gender, the sex that the couple wanted. Because there you had a direct opposition of the injunction, do no harm. Even a first trimester abortion has a surgical risk. One of the participants in that consensus conference said that it was similar to the problem of whether or not a doctor should perform cosmetic surgery. Do you put your patient at surgical risk just to lift her jowls a little? There is a risk involved, so do you do no harm, or must you respect the wishes of the autonomy of your patient who wants that abortion to be performed? So genetic screening has confronted physicians with that ethical dilemma since its origins. Yeah.
One of the things that the ethical decision-making and moral pioneers, we need to look at the role of the government.
Yes.
And one of those things that is very evident in this day and age is the use of prenatal testing, amniocentesis, and especially in maternal aging and that. Now there's a panel of, depending upon what state, and it's mandated by the state, now there's a panel of recommended genetic screenings during the prenatal period. How do you see religious leaders working with the government to help in dealing with the large number of genetic tests, which are 20 plus, in many cases even more than that, 35 in some states?
Well, before, yeah, I'm going to summarize the question. Thank you for asking. I need to summarize the question in part because people couldn't hear it, but also in part because I think that you have misunderstood several different things that are happening at the same time. So the question was, how should people of faith, religious leaders, interact with the government on questions about mandating genetic screening for a larger and larger number of diseases? Is that a fair summary of your question? Let me just correct what I think are a couple of misapprehensions in the question. There is only one form of genetic screening that is mandated by government, and that is newborn screening, which I have not talked about. In fact, every person in this room who was born after 1970 and who was born in the United States has already been genetically screened by order of a government and without parental consent. And that screening occurred on the first or second day of your life. A pinprick was made in your heel, and a tiny bit of your blood was put on literally a thing that looks like an index card. It's called a Guthrie card, named after the person who developed the test for the chemical that is produced in the first of the genetic diseases to be screened for amongst newborns, and that's PKU, phenylketonuria. Today, because of changes in the diagnostic technology, Newborns are screened in some states for as many as 35 diseases. The states can mandate which diseases to screen for. So there are some states that only screen for 5 or 6, and other states that screen for some number in the teens. This screening is mandated by the state. It's done except in Maryland and Wyoming without parental consent. And it's paid for, the costs are entirely paid for by the government. But the intention of these screening programs is to locate the babies who can benefit from treatment for the disease and to locate them early enough in their lives so that the treatment can start early in their lives. So this screening has, with 1 or 2 exceptions, no reproductive consequences or intentions. The kind of screening that you were referring to that is prenatal diagnosis through amniocentesis and its companion technology, chorionic villus sampling, is not, to the best of my knowledge, mandated anywhere in the world. What is mandated or made available is a better term. In a few states is something called maternal alpha-fetoprotein screening, which is done by, in prenatal care, blood samples are taken from pregnant women all the time, and one of those blood samples is tested for the presence of a chemical called alpha-fetoprotein, which indicates the presence either of spina bifida or possibly it indicates an elevated risk for Down syndrome. And in some states, California is one of them, that test is available free. It's not mandated, but it's made available free to any pregnant woman who presents herself for the test. So, to get to your real question, how should religious leaders relate to the government in these instances? I'm not entirely sure. Certainly, if we follow the model presented to us by the Cypriot Orthodox Church, religious leaders should encourage governments to do more of this, because none of it requires or even is advertised as leading to abortion.
Well, I would like to hear if there's religious objection to newborn screening.
Yeah, that's a good question. Does anyone know of religious objections to newborn screening, which, as I just said, is done for the purposes of locating individual babies who can be treated? Yeah.
We had a case in Nebraska that went up to the Supreme Court in which a family with unaffiliated religious convictions wanted to refuse the screening, and they were not given that opportunity. The Nebraska Supreme Court said that they could be compelled to present their children for diagnosis.
That they had to
Yes.
present their children for diagnosis.
Exclusion in Nebraska.
But in any event, these folks were religiously unaffiliated.
Right.
Did everyone hear that? No. Do you mind if I just repeat it? In the state of Nebraska, a couple refused to present their child refused to allow newborn screening to go forward, and the case went all the way up to the Supreme Court. They were religiously unaffiliated, but they didn't want it to be done, and the case went all the way up to the Nebraska Supreme Court, and they were required to present their child for newborn screening. I should also say that the mandating laws for newborn screening are state laws, and some of them provide for what's called parental opt-out. The problem, if you regard it as a problem, is that parents are not told that they can opt out in those states. Yeah.
Tennessee does permit religious objections to newborn screening, and I will just mention that about 15 years ago, I remember a child being and it turns out that we have a large Amish community in this area, and they routinely do not get newborn screening here. That's interesting because the practice in Pennsylvania is actually quite different.
Right.
And I remember a child being admitted to the hospital here who had new onset of maple syrup urine disease, which the parents noticed because their Amish newsletter said, if your baby smells like this, go to the hospital. So the baby smelled like that and they went to the hospital. So
What's the nature of the objection, though?
I think really, you know, just not wanting anything to do with any government. I mean, because they don't get immunized either.
In the Mennonite community, it's merely a matter of they just are separated. The Amish and Mennonite are totally separated from the outside world. I'm sure you're aware of that. So going to a hospital means being in the common world.
Right. Did everyone hear this exchange? I need to summarize it. Ellen Clayton said that in the state of Tennessee, there is by law a religious opt-out, and that the Amish in Tennessee do not have their baby screened as newborn because of this provision, although it is the case that the Amish in Pennsylvania do have their babies screened. And then Gail asked if anyone knew exactly what the religious objection was, and the consensus of opinion here in the front was that the Amish, like some of the Mennonites, just won't participate in anything mandated by a government or in institutions like modern hospitals. I know for a fact that there are other Mennonites who do. In fact, there are Mennonites who are physicians. And
I'm from central Pennsylvania, so I know both sides of the coin you're talking about right now. One other thing that you had mentioned regarding the Cypriot that concerned me was you said they are mandated to have this testing before they can get married.
right.
So it's not mandated by the general population, let's say they want to be celibate, or they,
No, you don't have to.
I'm just thinking about premarital sex.
Well, the Cypriot government, like several governments, and the Cypriot church, like many churches, does not recognize the existence of premarital sex. So, yes, it is a premarital screening program, and it's mandated in precisely the way that you just explained. You can't get married without the test. If you don't want to be married, you don't have to have the test. If you want to be married by a secular authority, and only a tiny fraction of marriages in Greek Cyprus are done by governmental officials. I think something, when I was there in the late 90s, it was something on the order of 1.5%. Well, then you don't have to take the test, although the couples do, but they're not mandated to. I should also tell you that in Turkish Cyprus, which is the northern third of the island, premarital screening for beta thalassemia is mandated by the legislature, by the parliament. Yeah, the gentleman. Yes.
What do you believe should be the course of action for doctors who are counseling religious individuals, but the doctors themselves don't belong to the religious community?
There's a very good question. Did everyone hear it? No. The question is, what would I counsel a physician who is counseling, or any other medical professional, genetics counselor, for example, who is counseling a individual or a couple about genetic screening, but who the couple does not share, or the couple in the medical profession who do not share the same religion. We are actually going to hear a paper on that subject tomorrow, I think. So I won't, I think, pre-announce the conclusion of that paper. But what I would personally do is try to help the couple find a informed and sympathetic religious advisor. And unfortunately, many religious advisors are not informed about these clinical matters. Yeah.
Could you just say a little bit more about this program on the Greek island, where you said since the 1990s there have been no babies who are afflicted? Does that mean, so the empirical evidence, does that mean people are choosing different marriage partners, they're avoiding babies, or getting abortions, or?
That's a very good question, which I intend to answer tomorrow morning, but I'll give you a preview. It's absolutely clear what's happening. No, they are not choosing different marriage partners. Yes, they are choosing prenatal diagnosis and abortion. And I overstated the case when I said that no babies have been born in Greek Cyprus. In fact, no babies have also been born in Turkish Cyprus since about a decade into mandated screening. Few babies have been born to thalassemic couples, that is, homozygote couples, who have met at the thalassemia clinics and married each other and chosen to have an afflicted baby. And both Cypriot governments support that decision by providing medical care for those babies. Yeah?
I was wondering, you mentioned that, well, all of the examples that you mentioned were extremely severe genetic disorders. And I was just wondering what, given that there's a broad spectrum of genetic diseases, you know, what scale of severity is required to invoke this?
That is the $64,000 question, about which there is an enormous amount of dispute. Some of which dispute will be addressed in this. For example, the most commonly screened for genetic condition is Down syndrome. But there are a very large number of people, many of them disability rights advocates, who do not regard that the termination of a pregnancy with the termination of a Down's pregnancy as an ethically appropriate action. Similarly, another dreadful genetic disease, sickle cell anemia, can now be treated in such a way that the disease can't be cured. It might be cured in some instances by a bone marrow transplantation, but those are instances in which it's been successfully cured or rare. But the symptoms can be alleviated principally by what penicillin prophylaxis, which has permitted, since it became available and commonly prescribed, persons with sickle cell anemia to considerably moderate the number of painful episodes that they have and to extend their life, not yet to normal lifespans, but way beyond what it used to be for untreated sickle cell disease. And because that disease can now be treated reasonably well and not nearly with as much difficulty or expense as beta thalassemia, many carrier couples will not terminate pregnancies with afflicted fetuses. There are other people in the world who think they should, but there's no place that I know of in which they're required to. Yeah.
To follow up on the statement you just made, is there some place that requires the termination of a pregnancy as the result of testing, prenatal testing?
The newspaper, to the best of my knowledge, there is no such place. That is, there's no place in the world in which an abortion consequent on prenatal testing is mandated. But the newspapers carried a story which I confess I didn't follow up, sometime in the late 1990s, that the government in Singapore had passed a law requiring the termination of pregnancies with Down syndrome or other conditions that produce mental retardation. About a week later, the New York Times carried a story that the international uproar had been so extreme that the law had been withdrawn. Maybe extreme isn't the right word. The international uproar had been so loud that the law was withdrawn. Does anyone know any other answer to that question, whether there's any place in the world where abortions are required consequent on prenatal diagnosis? There are a lot of experts here, so. Did you have a question?
I was just going to very quickly follow up. Does the advent of universal health care and those sorts of systems change the perspective, either in the public or in any other community, about how, given that long-term care is now sheltered by different, does that change the perspective?
That's a very good question. A change of perspective would have to be registered in a different outcome. That is, in some places which do have universal health care, we'd see a change of perspective if we saw an increase in the number of babies being born with one or another of these really serious diseases, right? Well, to the best of my knowledge, we don't see that.
I would like to thank Professor Cowan, and if anybody wants to continue to come up and talk with her, I would really invite them to do so, but please join me in thanking her for her aid.
Thank you. And thank you for your very thoughtful and interesting questions.